Scientifically speaking, we're sharing the view. From labs to clinics, breakthrough shining through, with minds that inspire and stories to unfold. Scientifically speaking, the future's being told.
Welcome to Scientifically Speaking with Christine on Oz Arab Media, where we bring expert insights on health, science, and innovation to help you make informed decisions about your well-being. Before we start, I'd like to give a special shout out to Laurent, who took care of my hair for today's episode. Today, we're tackling a topic that affects millions of people worldwide: weight management and bariatric surgery. Obesity is not just about appearance. It's serious health conditions linked to many other life-threatening illnesses. So I'm thrilled to be joined by Dr. Mark Magdy, a highly skilled Australian general surgeon and bariatric specialist specializing in minimally invasive weight loss and metabolic procedures. Dr. Magdy, thanks for being with us and welcome to the show.
Thank you, Christine. It's an honor. Thank you.
No worries at all. If I can start quick and easy, it is a major issue about weight loss, especially in Australia. And a lot of people want to know whether it is a good idea to do gastric sleeve or the gastric bypass. So if you can quickly and with simple words tell us, what's the gastric sleeve exactly?
A gastric sleeve, it's the most popular operation worldwide, and it's the most popular operation in Australia.
Right.
About 80% of the cases performed in Australia are sleeves. It's a great operation, but like all operations, it's got its limitations.
Right.
Essentially, what happens is you're reducing the volume of your stomach. And so you're reducing it to varying sizes. So not all sleeves are the same. And you can control how wide or how tight a sleeve can be, depending on the bougie or the guide size that we use.
Mm-hmm.
So there is a misconception that all sleeves are the same. That's not the case. Even if you look at between different countries, so in the US, for example, they'll leave a certain portion of the stomach, whereas in Australia, we tend to resect what we call the antrum, or a little bit near the end of the stomach.
Right.
And both has its advantages, both have their disadvantages, but it's one of the debated techniques for sleeves.
So are we safer kind of in Australia, or it's not related to safety?
I think what the difference being antral sparing or antral resecting, they're both equally safe. We've got great results in terms of your complication rate, at least from our BSR, which is the Bariatric Surgical Registry in Australia.
Right.
The complication rate's 1.5% of sleeves.
Right.
So it's pretty low risk, regardless of the thing you have. It's just a matter of whether you think cutting a little bit more is more advantageous, or leaving a little bit more room has its advantages as well.
Amazing. And on the other hand, what would a gastric bypass be in difference to the gastric sleeve?
Yeah, so generally speaking, we classify these procedures into restrictive or malabsorptive. Now, the term malabsorptive has been superseded with hypoabsorptive because people don't like to think of malabsorption, so it's hypoabsorption. But essentially, the sleeve is a restrictive procedure. It's the same class as things like, say, the gastric band, which is the predecessor, whereas the hypoabsorptive procedures, that includes bypass, and there's different types of bypass. So you've got a Roux-en-Y bypass, you've got a single anastomosis bypass, and you've also got a SADI, which is another form of bypass.
Right.
There's a misunderstanding. They think there's one type of bypass. That's not the case. And once again, like the sleeve, where you can control how wide or how tight your sleeve is, you can control how much you bypass, whether it's 1 meter, 3 meters, 4 meters. And what we know is that there's a huge variation in patients' small bowel length. So it's anywhere between 4 meters to 8 meters.
So that's happening in the intestines while the other one is happening in the stomach. That's like the simplest way we can. You're right.
Yeah, the sleeve would be a stomach-only operation.
Mm-hmm.
Whereas a bypass, you make a small pouch and you reroute the small intestine.
Wow.
So you can imagine there's two components to it, the small bowel and the stomach, whereas a sleeve is a stomach-only operation.
So it's more invasive?
There's definitely higher risks. So if you can compare the data, there's a 5.6% complication rate with the Roux bypass and about a 3.9% with the one anastomosis bypass. It's definitely more technical So it's a more complex operation.
Right.
It's usually associated with longer operating times, but it's generally from a long-term point of view that you get more sustained long-term weight loss.
Oh, okay. So between sleeve versus bypass, who is each best for?
So this is where I tell people it's what color is best suited to your hair. Okay, so you got to customize it according to the patient. So some people want blonde, some people want brunette, some people want a darker blade. It's the same concept with sleeve bypass. You got to look at the patient as a whole, and you can't generalize. Everyone needs a bypass and everyone needs a sleeve, because that's a flawed way of thinking of it. So you've got to think about the patient in terms of what medical problems do they have? Are they a diabetic? How long have they been a diabetic? Are they on insulin or they're not on insulin? How old is the patient? Whether they're a female who's in childbearing age or non-childbearing age. These are all considerations. Whether they've had previous surgery. Do they have any inflammatory bowel disease or conditions of their small intestine? Do they have a hernia? Do they not have a hernia? These are all, you got to really customize the approach that you take. And then you pick, this is more suitable for that person and the justification, and this is more suitable for that person. And even between that discussion gets more complex. Do you give the person a single anastomosis bypass or a mini bypass, or do you give them the root bypass? And I think a major consideration is reflux. Reflux is a big deal. And that does help skew, one to the other. But essentially, it's definitely not everyone gets sleeve, everyone gets a bypass. It's really customizing the approach to the patient.
Amazing seeing it from a medical background, because usually people like, I just want to lose the weight. I just want to shed them off. Let's just do both or either. I don't care. But obviously there's a lot of complications behind it. So better go to the professional's advice. If I may ask, what's the best or the most typical total weight loss and metabolic improvement at between 1 to 5 years, whether it was a sleeve or a bypass, and how do you compare it on long term?
Yeah, so we always talk about resolution of comorbidities. That's typically the things like high blood pressure, diabetes, cholesterol. We talk about sleep apnea. These are all potentially reversible. And a lot of it comes down to how long have they had their condition for and how bad is the condition. So it's a very different scenario. If you've got a diabetic who's been on tablets for 1 year, you can't compare them to someone who's been on insulin for 10 years. So the remission rate is very different. And so sometimes we get complete cure. We reverse the diabetes completely. And sometimes we don't get cure, but we reduce their requirements enormously. So they go from 3 different medication to 1 medication, or we go from 100 units of insulin to, say, 10 units of insulin. And that's a significant improvement. In terms of sleep apnea, we see a lot of patients who have a sleep apnea machine where they lose the weight. They do a repeat sleep study and it's gone. Blood pressure, we see very commonly. It's gone. They don't need to take antihypertensive medication. And the same for cholesterol.
Amazing.
The data usually, so we follow all patients indefinitely, but it's more intense in the first, say, 3 years and yearly after. And what you do see is that you got about a 30% total body weight reduction in a first year, almost for all the procedures, a bit more powerful for the mini bypass or the root. And then at 3, 4, 5 years, you see a slight weight regain, but we're going from, say, 34% to 31 or 29%.
Right.
And a lot of it does have to do with the set point and returning your body back to its natural set point.
Yes.
Fortunately, we have a lot of drugs, as you know, on the market, and they're definitely helping. They're helping for weight regain. What we don't want to see is a complete weight regain. That's not. So we tell people as soon as you start to notice that there is an element of weight regain, then come in early, such that we can avoid significant weight gain. But there's always that natural inclination to put on, obviously not the entire amount, but a little bit of weight, typically at a year 3 to 5 mark.
Right. But the total weight gain, we can't say the surgery didn't or failed or it didn't have a success. Maybe it's a lifestyle that the patients are coming back with, right?
Correct. So what we tell people that the surgery will give you a big head start. Okay. But there's a maintenance phase that the patient has to be responsible for. So essentially we can, make you lose 30, 40, 50, 60 kilos. But unless there's a change in mindset, unless there's a change in what you eat, the volume that you eat, and the amount of activity that you do in terms of exercise, then that definitely, I mean, if you continue to do exactly what you did prior to the procedure, it is very likely that you will return to what, the previous, never to the same weight, but there will be a significant element of weight gain. So we tell people it's a strategy, it's just a tool, it's a mechanism, but essentially there has to be fundamental changes in terms of your mindset, your relationship with food, your desire to exercise. They have to come and work hand in hand with your procedures.
Lovely. All sounds very theoretically perfect, but is there any risks and side effects, whether on short or long term, that any patient should expect along the way?
Definitely. There's no doubt there are expected and there are unexpected. And what you see, like any procedure or any medication, there are unfortunately unfortunate side effects or potential complications that can arise. We are fortunate that they're extremely rare, but they do happen. And some of the things that we really fear are a leak, and that can happen to patients, bleeding, especially in the short term after a procedure. We talk about anesthetic risks. We talk about clots, the clots that can develop. And then longer term, there are other things that are almost inevitable. For example, people say, my taste buds change, my bowel habits change. Wow. They'll say, my hair's fallen out. Yeah. Now, these things return, and you do normally get complete reversal. However, during that period of time, you can imagine for anyone that's losing hair, it's very anxiety prone and stressful, and you think, when's this going to stop? And for patients that experience, say, for example, constipation, it's not a pleasant feeling. Right. So that can be quite confrontational. So we tell people, expect this. This is potentially going to happen. And if it does happen, well, then, you're aware of it. We can treat it. If it doesn't happen, well, that's great. It's fortunate that hasn't arisen. But I think, like anything, being prepared, being fully informed, knowing the risks of the procedure, that's essential for proper informed consent.
Great. Can we say we have higher risks in a sleeve or higher risks in a bypass, or are they expected at any?
No, so there's two components to everything. When we talk about risks, there's patient factors.
Right.
Okay? So if your BMI is 60, you're not the same risk as someone whose BMI is 35. Mm-hmm. If you're a diabetic who's on blood thinners, who's had previous operations, who's had previous bariatric surgery, and you're having a revision, by definition, you've got higher risks. So they're what we call patient factors. Then there's the technical factors associated with the procedure. And definitely, so when you look at the BSR, the Bariatric Surgical Registry, a bypass has higher risks. Why? Because you can have problems with the small bowel, you can have problems with the 2 bits of small bowel that you join. And we talk about immediate complications, like short-term. We talk about intermediate and long-term side effects.
Okay.
And long-term things, people get worried about nutritional deficiencies. That is a problem. Internal hernias after a bypass. Whereas a bleed or a leak, these typically happen early. And so so to answer your question, yes, overall, 1.5% primary sleeve complication rate, 5.9% primary bypass procedure leak, or complication, sorry. And then, of course, the patient factors. So they're not without their problems. No surgeon, no patient, no one wants, obviously, an adverse outcome. But unfortunately, they do happen. And fortunately, the mortality rate, so someone dying from marriage, is incredibly rare. So it's not common.
Okay.
Which is, and we've shown that they're almost as safe as a gallbladder or some of the other general surgical procedures that we perform.
Lovely. Now that we've learned really what is a sleeve and what's a bypass, and if I, as the audience, I'm looking into it, who is really eligible in Australia today for a sleeve and or a bypass?
Okay, so we've got criteria that would qualify. Now that's changed somewhat because of the medication. And so what we're seeing is a lot of people go on medication, they lose a significant amount of weight, and now they've become ineligible for the procedure. Okay. So then we say to them, okay, do we wait for you to put your weight back on? That's counterproductive. So this is a gray area as well. And that's a case-by-case basis. Right. In terms of the hard rules, who gets an operation, we talk about BMI greater than 30 with metabolic associated problems. So high blood pressure, insulin resistance, high cholesterol, diabetes, obviously, sleep apnea. or patients with a BMI 35 without associated comorbidities. Which procedure you pick, really, you have to customize it like we spoke earlier.
Yes.
But the guidelines per se are BMI greater than 30 with metabolic associated diseases, or BMI greater than 35 on its own.
Wow. Okay, and can you walk us through a little bit with the pre-operation pathway and the preparation to this surgery, whether we decide to go for a bypass or a sleeve?
Yeah. So with any procedure, I tell people you've got to be mentally ready, you've got to be physically ready, you've got to be psychologically ready. So if you're feeling pressured, you're stressed, you're not in the right state of mind, then don't go ahead till you're comfortable, till you've made your decision and you're firm on it. That's the patient preparation. Right. From the surgical preparation, we like to educate people, we like to tell them, and I say to everyone, you don't walk into the first house and buy it. You like to do your market research. You want to know what's available, what's the street value, so there's a lot of preparation that I tell patients, and a lot of it, we give them the initial consultation, we explain to them, and then we say, come back after, because you'll generate some questions, you want to know more. So come back and we have another discussion. Fortunately, most of our operations are not an emergency operation. These are elective cases, so you have the luxury of waiting. This is not like, for example, God forbid, cancer surgery, where we're time sensitive. We've got to get things moving quickly.
Right.
In the bariatric or metabolic surgery, we say to people, prepare adequately. So we like to put them on a very low calorie diet before the procedure. That's at least 2 weeks, sometimes even longer. In some patients, we like to make sure that they're psychologically suitable, that they don't have underlying eating disorders, or they might need further workup to make sure that they're ready and they're in the right psychological state. Right. From a physical point of view, I tell people it's like running a race. The more you practice, the better you're prepared for that race. Okay. If you take up a marathon and you've never tried to run a marathon, you're going to struggle really significantly. Whereas if you've tried running and you've had adequate practice and you've run previous marathons, then I think you're going to be more prepared for what to expect. And like anything, having the right resources, having your vitamins, having the appropriate support at home or outside of home, work support, that makes a big difference in your journey and being able to cope. A lot of people like support groups. Some people don't. So some people like to discuss their journey with others, and some people think it's very private. It's their own journey. And so really, once again, like anything, it's going to be very individualized. It's very personal adventure, like a personal journey, and we don't like to impose one size fits all model on anyone.
Amazing. You did mention something about the low carb diet before going on to a surgery. A lot of people would say, I'm going to go into the surgery and shed the weight. So why am I need to do a diet before that? Not knowing maybe there is medical, explanation behind that. Can you just brief us, why do we do this low carb?
Yeah. So we call it a very low calorie diet on purpose. And it's like a preparation. So there's multiple factors that's good. One is compliance. You can show as a patient that you're compliant, that you're going in there with a positive mentality. It's like someone says, I want to quit smoking, but then they go and smoke as much as they possibly can before it. It's just entering into something with a negative mentality that, I'm just going to eat as much as I like. So that in itself is a good compliance. Okay, so they're showing they've taken initiative. From a surgical point of view, there's a huge advantage. So what happens is when you go on a very low calorie diet, a lot of the fatty liver is actually resolved. And so what we see is during the operation, one of the very first things we do is we lift the liver so we can access the stomach. Right. And so when you've got a big liver, and this has happened, and it's happened to colleagues quite recently, where the liver was too big, simply they had to abandon the procedure because the liver prevented them doing a good sleeve because it obscured the vision. So from that point of view, also it decreases intra-abdominal fat, and it makes the liver favorable that you can lift it to actually proceed with the operation. Right. And then the other thing is that you enter into almost ketosis. I mean, some patients don't get to that stage, but essentially you're entering into a fat burning phase, so that you're already ahead before you enter the surgery. And so the weight loss continues on. Post-procedure, you're going to be on liquids anyhow. So this is a good test. So when patients come to me and they said, I was on the liquids and I just couldn't tolerate it, I say to them, look, you've got to really reconsider the operation, because if you couldn't cope now, what's going to happen post-procedure? Because
Right.
it's imperative to be very compliant with your post-operative diet, because that's when bad things can happen if you don't comply.
Amazing. Very informative. Thank you. What does a good aftercare look like from the patient's point of view and your clinic's point of view?
Yeah. It's a partnership. So you work hand in hand. It's like a doctor-patient relationship. It's a whole team involved.
Right.
So if one person isn't pulling their part, then this is always what I say to patients. I say, if you have a great result, you make my clinic look good. So we both have a vested interest in you doing well. We're both happy. You have a
Yes.
great result, my clinic's good, everything's fantastic. If you have a bad result, our clinic looks bad and the outcomes are not good. So we both look bad. So when you work hand in hand and you've got a good working relationship with the patient, then the outcomes are better. And so what that support involves is, obviously you have your surgeon that performed the procedure. You've got the dietetic support. And it's like having your first child. You don't know what to expect, and what's normal, what's not normal. You have no idea. When you've had a second or third child, of course, you kind of get used to it. But for most people, they have no idea what to expect. Is it normal at week 1 to experience this? Is it normal at 6 weeks to have a bit of a plateau? These are normal. We do this day to day. And so we can inform the patient. And the dietitian will guide the patient along the way. And everyone has a different journey. Some people get comfortable very quickly. They progress on their diet quickly. Some people don't. They take a long time. And there's no right or wrong. But as long as you're working hand in hand with the team, then you get better aftercare. There's also psychological support. Some people really struggle. They hit plateau phases, or they get stressed about hair loss, or they say, "Oh, I've plateaued. Is this stopped working?" And so there's a real psychology and a mentality of how to cope with the post-operative phase as well. It's not easy. It's not easy to be highly compliant, to experience different highs and lows with the surgery. There's body changes. So that's got its own psychology. And so the combined effort of the whole team with a compliant patient is the best outcome. What we don't like to see is what we call, so for example, sleeve and leave. Sleeve and leave is you get an operation, bye-bye, we never see it. No, it's not good for anyone, but you don't know what the outcome can be. They can come back and lose 40 kilos. They can come back and gain 40 kilos. We don't know. But I tell people...
True. And that's maybe between brackets we can say, do not go overseas, do it and come back, because you might need this whole journey during the sleeve.
Yeah, and there's a relationship that you develop with the patient, that you've operated on the patient. There's a responsibility, there's a follow-up responsibility. But when the procedures are done elsewhere, overseas, or wherever it may be, like there are obviously people that travel interstate and they have to for work, family, whatever commitments, and we always welcome the doors open to anyone. But to see someone pre-operatively, post their procedure, and guide them through the next guide, it's very rewarding and satisfying for the team that we see great results, the patient's happy, and I think it forms a good network between the two, like the patient and obviously our team.
Amazing. When do we think we really need a revision or a conversion, whether it's from sleeve to bypass or vice versa?
Yeah, so revisions happen for multiple reasons. One of the most common is reflux. So unfortunately, after a sleeve, there is a high incidence of gastroesophageal reflux or reflux disease. And so we try to avoid, if potentially, but sometimes the patients don't respond to antiacid medication, or they develop severe problems. So that can be a reason to convert to a bypass. There's also patients who do have weight regain, unfortunately, typically around the year 3 to 5 mark. We tell them we try, obviously getting back on track in terms of diet and exercise. Sometimes we try medical therapy if that's sufficient. If there's 7 to 10 kilograms, that might be the best option. But in some patients who are unable to lose the weight for whatever reason, then converting them to there's 3 options really. There's a SARDI, there's a single anastomosis gastric bypass, or a Roux-en-Y gastric bypass. Often there's problems with the sleeve itself. For example, there's something called angulation, or there's some torsion of the sleeve. So that's a structural problem. And so sometimes that might need to fix or correct that defect, and that might need a revision. Generally, in the bypass patients, there are procedures, we call it distalization, That's not commonly done, but you can perform a distalization. What you do see is some people unfortunately get severe dumping.
Oh,
And
yes.
often that can be an issue, can be
Yeah.
quite difficult to treat. And sometimes you have to reverse their bypass. That's one of the advantages of the bypass, that there is a reversibility to it.
Okay.
But it is something that we try to avoid if possible. But if there are complications, then sometimes, we do need to reverse our procedures.
Wow. In a lot of cases, a bariatric surgery is advised for pregnancy and fertility. But why it's the case and why is it suggested to delay conception if we already did it for that purpose?
Yes. So, yeah, there's been a lot of studies in terms of fertility. A woman's fertility or a man's fertility can significantly improve with weight reduction. So a lot of women suffer from PCOS, for example, or some men have low testosterone associated with being overweight. And so what we find is that when they lose weight, and in particular when they start to exercise or motivate them to exercise, then they get a rise in testosterone levels. They can get improved sperm fertility. Women can have improved fertility. What we don't want is when they're in the rapid weight loss phase, which is typically within the first year post their procedure. We do not want the women to become pregnant because that can be associated with significant nutritional problems. So we tell women, if you're considering having weight loss surgery, great, but please delay trying to conceive for at least 1 year post your procedure. After the first year, then we do recommend obviously being compliant with vitamins, but then you can try to conceive. And generally speaking, we have better fertility and improved outcomes. Even for women who have had, or they do fall pregnant, there's been significant reduction in the complications associated with the pregnancy in women who have lost weight. So there's a decreased need for cesareans. There's a decreased complication associated with pregnancy in women who have undergone the procedure.
Lovely. We've been talking a lot about the sleeve, the bypass, the types of bypass. Are there any newer or innovative options coming up the sleeve into Australia, or anything else we can, if you don't want to go very invasive?
Yes. There's a lot of new technologies that are coming out. There's a lot of that are already there. So there's something called the endoscopic sleeve. The endoscopic sleeve is with a gastroscopy. Surgeons and gastroenterologists, they go inside the stomach and they tighten the stomach. They plicate it. And so essentially it's a reversible procedure. It's not as aggressive as some of the surgical procedures, but the weight loss is not as pronounced. So we typically see it in the lower BMI cohort. A lot of the time it's combined with the GLP drugs. And so we are seeing some favorable results. There's a big study called the MERIT study, which did show that there's quite favorable outcomes. It's a modest weight loss. It's not as aggressive as some of the surgical procedures. We're not seeing the huge weight loss that we see, but there's definitely a role for that as well. There's the intragastric balloons. So they're less popular now. They were more common. And there's a self-swallowable balloon. It dissolves on its own, passes within 4 months. We're also seeing new technology. It's actually the surgeon who invented the sleeve gastrectomy. He's invented 2 magnets, and they're doing magnetic procedures. And the magnetic procedures essentially make a bypass through 2 magnets. You swallow one magnet and we place a second magnet. The 2 stick together. And then over time, they'll slowly cut through and make a joint. This is quite new and it's still in the trial phase, at least in Australia, that is. So we have done these cases in Australia. Around the world, they've got FDA clearance. So in the US, they've got FDA. In parts of South America, they're doing them commercially. And also I think in the United Arab Emirates, they've got commercialization for the procedure.
Amazing. Do we find the same amount of weight loss in newer versions of weight loss surgeries like the sleeve and bypass, or do we still stick to the old ways when we want to shed a lot of kilos?
Yeah, the traditional procedures, so that is the sleeve and the bypass and the variants of the bypass, whether it's a single anastomosis, a roux, or a SADI, these are our kind of gold standard. They've been trialed, they've been tested, they've been around for many, many years, so we know those results. These newer procedures are still in the evolution. They're in a newer phase. So we're seeing at least the early results, but I can't say we have 5-year or 10-year data on these procedures. So we're still in that evolution where we're learning. But what's good about it is that we're getting more and more treatments. We're getting more and more modalities. We're getting different techniques. They're getting less and less invasive. So a lot of them are being performed as a day procedure. So you go in, you go out the same day. So there are those advantages of these newer techniques, but we're not seeing the significant big weight loss that we do see in these traditional procedures.
Amazing. And doctor, if you don't mind me asking about the GLP-1 injections like the Ozempic or the Mounjaro that we're seeing trending at the moment, how do you frame these medications versus a surgery? And where do you think they complement each other?
Yeah, so these are very topical. And over the weekend, Serena Williams, she spoke about her usage of it. And this is an elite athlete who's struggling with weight. So it just goes to show that regardless of how athletic you are or your profession, I mean, Oprah Winfrey spoke about it, Elon Musk spoke about it. These are billionaires that also have weight issues and maintaining the weight. So
celebrities, they stay on them to stay in good shape.
Yeah, correct. So it's a condition that affects everyone, regardless of your financial worth, of your social status. This is not. But essentially, what we're seeing or what we're generating, it's the concept of complementary. So it's a bit like in the oncology space, in cancer surgery or cancer conditions, we talk about radiotherapy, chemotherapy, and surgery. It's not one's better than the other. You use them hand in hand. They combine together. And what we say is, do you want to trial the drugs first, see where your weight loss is, and if it's not sufficient, you can have surgery. Alternatively, people will have surgery, and if they want extra weight loss or they have weight regain, then we put them on the medication. So it's not one or the other. They're not, mutually exclusive, but they're complementary to one another. And so we talk about, surgery plus medication or surgery plus another modality. And I think they're great. I think they're very effective. There are side effects like any other medication, unfortunately. They're not common, but they do happen. But we do tell people, if you feel comfortable starting on a medication, sure. And if you need supplemental surgery, sure. If you want to start with surgery and you need supplemental medication, that's also very reasonable. So I don't think there's a right or wrong answer. I think it just gives us more and more tools to fight obesity.
Amazing. Before we wrap up, I'd like to do a little game, if I can say. It's like a myth-busting round. We hear a lot of people talk about or believe in around this topic. So if you don't mind me starting with the very first one, surgery is the easy way out. What do you think about yes or no, and why?
Okay, that's definitely incorrect. It's not the easy way out because if you speak to anyone who's had weight loss surgery, they'll tell you it's extremely difficult. You've got to put a lot of effort in. You've got to put it's a big commitment. There's the preoperative phase. You're on a very low calorie diet. People, they feel a little bit tired. Then they have surgery. Surgery's got its own recovery phase. Then they have to juggle working or looking after their children and having the procedure. And there's a psychological difficulty to it. You look at food, but you physically can't consume that food. You have to stay motivated. You push yourself. It's definitely not a miracle, asset. It's not a miracle pill. It's not a miracle procedure. It's definitely not. It's to a certain degree. Some people say it's the harder way. It's forced them to really comply. So no.
So that's a no.
That's a definite no from me.
Okay. Sleeves always stretch back to the original size.
That's also a misconception. You can get some dilatation, there is no doubt, but they'll never stretch back to their original size. Right. What we do is when we want to get a volumetric analysis, we do something called a fizz CT. So the patients will drink a fizzy drink and it will blow up their sleeve on purpose. Then we get an analysis of the volume of it. And typically we see people sleeve from 250 mils, 300. A larger sleeve would be in the order of about 400 mils. That is larger. But that helps us assess the sleeve, the size of the sleeve, the shape of the sleeve, whether the patient's got a hiatus hernia, and that can dictate sometimes further management. You can re-sleeve a sleeve if it is too big. That does have a significant complication rate, though. The sleeve it's got about a 10% leak rate, which is very high. And usually it's a bigger sleeve. So we don't typically like to do that. We generally convert it to other procedures, but we like to trim the sleeve. So if you're going to convert to a bypass, for example, we would retrim that sleeve, make it smaller, and then convert it to a bypass at the same time.
But you said it might go to a sleeve, which is 400, you mentioned?
What's important is your original size. So
Right, that's my question. What's the original size?
Yeah, so depending on how tight you do the original sleeve.
Okay.
And so the volumes can be anywhere between, we see a tight sleeve would be 150, 170 mils. That's quite a tight sleeve. You get 200, 230. That's anywhere between 150 to 300 is typically what we see. Above 300 is definitely a wider, and less than 125 or 150, that'll be considered a tighter sleeve.
And a person before sleeve can vary anytime, anywhere from 600 and above?
Oh, yes. You can easily accommodate, 800-900 mils sometimes.
Oh, wow.
So, yeah, your volume can be huge.
Okay, let's go to the next one. Bypass means you can never absorb medications properly.
Okay, never say never. That's the... no, it's not... It definitely can affect the absorption of some medication. There's no doubt about it. We talk about it can affect antibiotics, it can affect the oral contraceptive pill, it can affect things, but it's not to the point where it will never. It's just if you take a medication where you need to keep a certain level. So, for example, patients who take, say, lithium or other medications, then sometimes you need to monitor the level to ensure that it's adequately taken. The bypass, we're not going to bypass all your small intestine. And a lot of it comes down to what's your total bowel length. So let's say, for example, there's a lot of debate. Do you bypass a meter and a meter? Do you bypass 1.5 meters in a mini bypass? Do you bypass 2 meters? Do you do a proportion? So, for example, some people say measure the total length and bypass a third of it. So they still have 2/3 to absorb. So to answer your question, definitely no, it's not forever. We do say you should be on multivitamins for forever, though, because there definitely can be long-term vitamin and mineral deficiencies if you don't take your vitamin multivitamins. Yeah. But yes, it can definitely affect things, but not everything and not forever.
Completely. Yeah. The next one is you cannot enjoy normal food again.
That's completely not true. You can definitely. What we tell people, and this is where the dietitians come in, they explain very carefully. They tell people, when you try food, have heightened sensation. So people like to smell food, so they get the sensation. They like to have small entrees, and they get very rich flavors. They can taste all the flavors. They can taste the food. It's just the volume will definitely be reduced. But you can still eat whatever you like. Of course, everything's within proportion. We don't like to restrict anything. We tell people have a well-balanced, rounded diet. You need to have your protein as a priority. We talk about fruit and vegetables. Have everything in smaller portions, but you can definitely enjoy every meal that you previously had. It's going to be a significantly smaller volume.
Amazing. I've got a few more, but I'm not going to go through them only because I felt we already explained them along our conversation today. But all of these myths, Doctor, unfortunately, are there in the audience minds because there is a lot of a TikTok and Instagram advices on rapid weight loss nowadays. What worries you the most about these advice online?
Yeah, the problem is that each individual is going to have their own journey, and whether it's good or bad. Now, unfortunately, people that have a great result are less likely to talk about it. That's just by nature. And people that have, unfortunately, quite a negative like to talk about it a lot and let other people know. So you sometimes get a very skewed opinion about what's happening. Right. And a lot of people give advice that's relevant to them, but it's not relevant to everybody else. And so what I tell people is it's good to hear the good and the bad, so you're aware that these things do happen. But take the advice from the professionals. So take your dietary advice from your dietitian. Take your psychology support from the appropriate trained professional. And take your medical advice from an appropriate specialist in weight loss, whether it's a surgeon or bariatric physician, wherever it may be. But what we find is in a lot of groups, people give other people unsolicited advice, and often it's wrong or counterproductive. And so they said, but my friend said, and I read this in Google, and like anything, if I read how to change a car battery online, or I take advice from someone, it's best to take it to the appropriate, mechanic, or because they'll do the correct job. But it's like anything on social media. There's good and bad. I just tell people that is not your source of knowledge. It's good to hear, but if you want a well documented, if you want to see experience, then we definitely advise that you stick to professional care and professional advice.
Amazing. I really thank you for all of this really informative information today. Finally, before we go, where can our listeners find you or know more about their personal weight loss journey?
Yeah, so I mean, obviously everyone's welcome. Our clinic we're located in Miranda, and obviously we're online, and we've got a great team. I work with some exceptionally talented surgeons at both St. George Private and at Sutherland Hospital in the public sector. So that we're very fortunate. We've got a great team, and I think the quality of care and surgeons in Australia is exceptional. So in every state and in every territory, there are some incredibly talented surgeons, and they're very likable. They'll always deliver quite exceptional care. There are a lot of online resources that are also available, and I always endorse. We have a society for Australia and New Zealand. We call it the SSMAS Society. It's a specific body that looks after bariatric care and bariatric medicine. It also includes allied health, nursing, dietitians, psychologists. There's a website, the SSMAS website, and you can locate different resources. There's a lot of patient resources on there. One of the best resources that I think is the ASMBS, so it's the American Society of Metabolic and Bariatric Surgery. They have an enormous library of information. It's very accessible. It's in simple and easy to read. It's very patient-facing, so it's a huge resource. And I think the ASMBS has done an exceptional job, and I think SSMAS likewise. We're also following those footsteps to create our own portal and platform.
Amazing. Thank you so much, Dr. Magdy, once again, for being with us today and for sharing your insights and experience.
Thank you very much, Christine. Thank you. It's a real honor. Thank you.
No worries at all. Before we go to our listeners, we hope today's conversation has given you not only valuable information, but also a sense of encouragement. If you're considering weight loss surgery, speak with your GP and a qualified bariatric team to find the safest and most effective option for you. This was Christine from Scientifically Speaking on Oz Arab Media. Until next time, stay informed, stay curious, and take good care of your health.